So those of you who were here last year, you'll remember that we departed a bit from the traditional ministerial keynote to more of a discussion and an interaction in terms of some of the important issues that are revolving around innovation in the New South Wales health system. So we decided from last year's triumph we would repeat it this year. And please welcome to the stage Jillian Skinner, the Minister for Health and Minister for Medical Research, and Mary Foley, who is Secretary of the Department. Please welcome them both. Very dramatic music. I don't think I can match it with my questions. I mean, the mot du jour is integration, a major focus in the last year, as it was indeed when we spoke last time. I mean, do we actually know what it means? I mean, it sounds like a pathetic question to ask first up. You know what it means? Well, that's comforting.
I've come a little bit prepared for that because I've been talking about this now for a while, but back in June 2009, when I was in opposition, I wrote a document called Making It Work. And here's what I said, among other things. I talked about development of partnerships which will provide a seamless range of healthcare services to people who need them, whether that involves hospital treatment or community-based primary healthcare services provided by general practitioners, pharmacists or other allied health professionals. I wrote that back in 2009, and it really is what drives me now when I think about integrated care. As a definition, there are many different models within that, but that's what I see as integrated care.
So Mary, I mean, you could spend all your money in a sort of dissipated way on this, or you could focus on priority groups who need it. What's in your mind in terms of what type of person, community or condition that you think needs the priority?
Well, I think that's the Minister's definition of integrated care was a very, very good one.
But you've got to say that.
But we don't always agree.
That's right. We have quite robust discussions. Yes. I think the particular focus, sort of technically, is about how to connect both the acute side oriented around hospitals and particularly the side of healthcare that we as a state health system are responsible for. And then all the other healthcare that goes on more community-based, though I always like to say we as hospitals are very much in our communities, but with general practice and a whole raft of other services which are not part of our organisation, but the patients moving back and forth between these all the time, and they're not distinguishing whether they're in public or private, state or Commonwealth funded services. So how do you get the right connectivity between those spheres, particularly primary health care and hospital care? For some people, that won't be the priority issue. They're mostly well, have an acute episode, take themselves to their general practitioner, and the general practitioner is able to help them, and then they go away again. They don't need to think about integrated care. Similarly, someone who has an acute episode and comes to RED and is admitted and so on and fine, and then returns to wellness and home. And we're not talking about those people. So I think the whole concept of integrated care, and you're right, Norman, we'd all love to, there's lots of different ways we can improve and connect care for people across the board, but where do we focus? It needs to be for those, targeted to those groups where to get really good outcomes of care and the right care, that those people, those patients need to be able to draw the dots for themselves, be supported to draw the dots between the various providers. And that means very careful targeting of who it is that you need to be approaching and offering these services to. And for us, who are particularly focused in hospital and acute care, we're much more used to the model where everybody comes to us and then we sort you out, whereas this demands us to actually think about more of a population public health approach of thinking of who's in our community and who do we need to think about approaching and addressing for to think about integrated care solutions.
So Jillian, it's almost defined by complexity then?
It is, and you know, every model of a project of integrated care will be different, and it will be tailored for the local place, but also the population. Whether it's a group of people who have chronic illnesses, disease defined maybe, people with diabetes or at risk of getting diabetes, or whether it's a population group where it's known there's greater disadvantage in health terms of an Aboriginal population. And there'll be different models, and there'll be different models if they live in the country or they live in the city. That's why it's such an exciting prospect, and why we've been very careful to engage locals in this. We can't develop this from on high. We can give it a framework and some resources, but it really is engaging people at the local level.
How, this is a question without notice really, Mary, how conscious should people be of the NDIS, of this National Disability Insurance Scheme coming in, where people, where yet another interface to coordinate with, and people say, well, maybe we should hang on when people have their own personal budgets, that's going to help us out as well. What's your view on that?
Well, I don't think we can hang on. I think we've got to be proactively preparing for it.
But you don't want a disjunction either.
Absolutely not. The NDIS is going to be a significant game changer, in my view, in two ways. One, for the particular population groups, physically disabled and mentally ill, that it will serve, but also in terms of being a model, which is going to change the dynamics of how care is organised for certain targeted groups of people who are eligible under the NDIS. And I think that will present models that we'll need to think about for others as well. So in mental health particularly, for us in health, in mental health, the potential impact is very, very significant.
I mean, Jillian, as the Minister, what are you expecting from the demonstration sites? You know, Western New South Wales, Western Sydney, Central Coast?
Okay. Well, we chose those three sites to give expression to what's happening in rural, regional and metropolitan, and frankly building on some great innovation and integration that was already occurring. I spent a large part of my life out visiting those districts right across the state, in fact, hospitals, other health settings and so on, and I knew there was some very good work with some very innovative people, and a lot of this is led by the imagination of the people on the ground. So what do I expect out of them? There will be different models depending on what they are, and also don't forget the rest of the districts, and they'll all be here saying, what about us?
Well, exactly, I was going to say, I mean, integration's happening everywhere.
Absolutely, and it is, indeed it is. And, you know, I go out to these districts, and I think of the North Coast. I went there recently, and they said, but here, look at what we're doing, and they gave me a brochure that they'd presented about their integrated care projects. They've got an opportunity to seek funding as well. And the reason we set it up with a central pool of money was to say, look, it's an encouragement, I guess. Here's some money, but we want you, local health districts, with some of your growth funds to come up with your money. So it's a partnership.
So skin in the game.
Skin in the game. And then the partners you engage, whether it's local health, local GPs, allied health professionals, a private provider, an NGO, you put skin in the game, because when people have got an investment in that sense, either in kind or in financials, they've got a much greater commitment to making it work.
What are you expecting then, Mary, of CEOs and board chairs in this, apart from skin in the game? I mean, it's fine tipping in some money. That's almost the easiest thing to do, even in tight budgetary times.
I think it presents a significant challenge for both our executives and board members, because we ask a great deal of them all in terms of the services we're primarily responsible for, and making sure that they are functioning as you know, an absolute optimum, because our first line of responsibility is the people. As I say, people look to us to keep them safe. We're the ones who are open and there 24/7 for people, and so that's a huge ask and the primary focus. But we are asking that our health services need to also look outside the services that we run and the needs of their communities and the other people, both in health services and other social services, who are there, and how we might work together. And this is a global challenge. Everyone around the world is trying to work out how to do this, both to connect between acute care and primary care, because they're a bit like oil and water, quite different skill sets and backgrounds, and also how to connect for many targeted groups between the health services and the social services. As I say, you can't begin to deliver a proper service to someone who's homeless, for instance. If they're, I'm thinking of a patient only living in a drain in Rushcutters Bay. You know, you've got to get a roof over their head and some basic social supports. Then you can deal with their presenting physical illness, and as well as then looking at the more underlying mental health issues for them that have brought them to the situation. And this is enormously difficult. No one has designed the perfect model or got the killer answer, but everybody knows we've got to find how to do this if we're going to be have effective health delivery systems here and elsewhere. And so it is a big ask from our districts, but I think our devolve model and the development of our model, where we look around and see our districts and networks coming up with all sorts of innovations within their community, are well placed to actually be able to design these solutions.
Jillian?
Yeah, and it's interesting, a lot of them are realising that it's actually helping them with greater efficiency with the resources they've got to run the hospitals, because there are many people for whom placement in an acute bed is not the right way to go. So this is actually enabling them to free up those resources for those that most need them. And look, I see down the back here the pop-up van that we use to promote early testing for HIV. That's an example of an innovation that has been fantastically successful, engaging people outside the traditional hospital setting, but can potentially save enormous health resources down the track.
No, you talk to some Medicare locals though, they say, look, the local health districts are under pressure to integrate, and you can understand on both sides. So the Medicare locals, some are frustrated because the LHD, the easiest thing to do when you're the CEO of an LHD is pull the levers for yourself. I've got my own community services, I've got this, I don't have to go and negotiate with somebody, I can just pull the lever and it happens. But so it might get you some short-term gain, but it doesn't actually pull in that integration. What are the levers? I mean, how do we change that so that they actually go further out than the services they control? Because that doesn't necessarily get you where you need to be.
No, but I think that the interesting thing with the Medicare locals now becoming primary healthcare networks is they are working very closely with us already. They're coming to us, so that there's an engagement both ways. And I don't think they'll see it as short-term, because they see the better health outcomes for their individual patients.
So what about innovative means of financing? Again, if you talk to GPs and Medicare locals, soon to be PHNs, they say, look, we're expected to do more, we're already flat out. Why don't we share in the gains? If we're going to save you on your frequent flyers coming in or whatever the project might be, why don't you actually have some innovative financing in an area that normally the Commonwealth plays in? Are you encouraging CEs and boards to do that?
Well, that's why we've got this money there.
Yes.
So they can be farmed out.
Well, we don't want to take on the financial responsibility for GPs per se, because that is the Commonwealth responsibility.
Much as you love Peter Dutton.
Much as I love Peter Dutton. But the reality is it is about us all putting our resources in. It's pooling resources, so to speak, so that we get a best outcome. Most GPs want this. They want a better outcome for their patients.
So are PHNs a dog's breakfast, or what's going to be happening there?
Well, you know, we unashamedly admit that we put in a proposition that we had 15 that matched our 15 local health districts.
Well, you're never going to get that.
We didn't. We got 9,
yes,
which was
good.
Yeah, and I think they've taken on board the kind of boundaries so that we can link with our local health districts. And you know, as I go around the place and chief executives and others, board members, board chairs talk to me about what's happening, they say, well, we're going to continue with the projects we've already started anyway. We've developed these relationships. We have these GP representatives on our boards, I should tell you. So we've got cross-fertilisation on our boards already. Those relationships are in place, whatever the PHN role eventually turns out to be.
Mary, you're happy with the way it will go? What are your
Well,
plans in place?
well, to be frank, I think New South Wales Health has done a great deal to support the Medicare local model and reach out in partnership to get the benefit and the advantage of working together. And so I'm confident on the back of that we'll be able to do the same with the primary health network. So I think our outlook and approach is going to be one of the key success factors, because we do need to have some kind of structural arrangement in primary health care to be able to bring the two sectors to work together.
And create the right incentives.
Yes.
So let's look at other enablers, and the big one is information, IT, and GPs constantly complain, if you trust us, and you say you trust us, why can't we get in behind the firewall, find out what the CAT scan in the local hospital showed, or the pathology, so we don't have to waste time and effort, and we know exactly what's happening, for example.
And we could say the same thing
Yeah,
back, why
goes
can't
to
we
it.
get into their medical director and see what they've got for their patient
Look,
record?
can I say that when I have just finished my turn as chairing the Health Ministers' Council, and the one item that I put on the agenda was integrated care. All ministers signed up. I think it was the first meeting that Peter Dutton attended, and he volunteered his contribution, information and data sharing. That was a hallelujah moment, because there'd never been that commitment from the Commonwealth before. So it's a starting point.
He's just got to get his department to agree to do it.
Well, he's got a new Director General starting, or Secretary starting, so I think that there's scope. And through the our Healthy Net,
Well,
we're
that's
already
the other
doing.
thing,
We've got trial models where it's happening already.
So we will be able to do it through the PCHR. That's not the same thing as a GP being able to come into our electronic record like someone within our system does. But,
so you'll push the functionality of the PCHR
and
to
we
the
are.
networks.
Our Healthy Net, as the Minister said, our Healthy Net project is in 5 districts and networks now, where it's been prototyped and ready to be, as part of the integrated care program, is being rolled out across the state, and that connects the PCHR into our record, but also then automatically populates the discharge summary into the PCHR, which is then available to general practice, as well as general practice information that they upload into that record being available into our system. And certainly I've been out to Children's Hospital Westmead, which is one of the prototypes, and been in the ED there and seen how this is being used all the time, and they've got a very large enrolment. So I think if anyone's here from there, I think it's more than half of the children presenting in the ED there will have a PCHR, and it's used, and it pops up on the on our EMR through Healthy Net. It also means that the information from the things we do are then back into the patient record and able to be accessed by the GP.
How do you get beyond the individual projects? So, for example, the system is still burdened, and you're not alone. There's variation between states, but by and large, anything up to 30% of people turning up at an ED is an avoidable presentation. There are avoidable hospital admissions, and much of that is due to lack of integrated care and stuff that happens in primary care. How do you move from where you are now, from demonstration sites, demonstration projects, to actually looking at the impact on this enormous unnecessary expense in the system?
Well, can I say that one of the great things about this innovation showcase, which I think this is the 3rd or 4th year now, is the projects and the examples that are seen. The idea of it is to then systematise them where it's appropriate, if you like. And some of the innovations are now through the system. And I think what we'll see is if some of these integrated care projects come up that people think, I think that could work in my hospital or my health setting, I think they'll spread that way. I'm not thinking this integrated care is going to happen overnight and solve every problem, but I think as people see the advantages, there'll be others coming forward. I've had one of the not-for-profit private providers saying, we're interested in joining forces with you in doing some of this for a particular client group.
Now, there's a lot going on in infrastructure build in New South Wales. If you look over the horizon, if integrated care works, does that change? Have you got in your mind, without making any commitments, how that might change your infrastructure and capital spend?
Did you notice on the hospital fly-through the other day there was a GP? I noticed that.
Yes, it was.
Yes.
It
I mean,
was.
I would love to have greater co-location of GP practices with our hospitals. There are some Medicare rules about that, but I personally think in the end, if sense reigns, we will do more of that, to be frank. And the other one is, I mean, there's a fantastic Health One down at Jindabyne that is in the process. It started off being one of the Commonwealth general practice enhancements. Then I think community health joined in. Then it's a Health One, which is state. It's now a whole health centre in Jindabyne, which has brought everything into it. A bit like a multi-purpose service, but without the inpatient capacity.
So my final question is, I haven't mentioned the word the phrase patient-centred care, because if integration is going to work, it has to be built around the patient. But what we haven't talked about is what do you expect of patients, families, carers in this great new beyond that we're planning here? What's their role, and how do we set those expectations? How do we build the capacity in patients to deal with this?
One of your earlier questions is how do we monitor, if you like, or get the outcomes from the local health districts. And some of those demonstrator models, when they're reporting back, because we're very committed to transparency, getting feedback on what we're doing, one of the criteria is patient and family and carer engagement. So if you're going to ask people to monitor, to survey your patients about how it's going, that means you're going to have to involve them in the whole process.
But it's more than engagement, because if you look at the evidence, for example, one of the huge things that you can do to improve safety in the labour ward, this is randomised trials done in Dublin, is have one of your family sitting by the bed, having a there. So it's more about control and who knows better about where you are in the system and the patient themselves. So it's a bit more of an active thing rather than just engagement.
Absolutely, I agree with that entirely.
If we get this right, in what we're calling integrated care, it should give patients and carers and families more confidence to be able to manage their care. That's not a buck pass to them, that not our problem, your problem, but much more that they've got the information they need, a sense of where to plug in, a better sense of, there's a lot of work we're doing across the board on patient pathways, and it's not only important to share that between various providers so they know the pathway
so
in
you
their
put the
geography.
pathways in the hands of patients.
But you're putting pathways in, so they've got some idea of who do you go to when, and if there is a sudden exacerbation or crisis, who do you call or where do you go? And that allows patients to take much more control for themselves by being more confident, by being better informed. And I think that's a very important piece of it.
The innovation that I chose for last year's Minister's Award was In Safe Hands. I saw it out at Orange Hospital and I was blown away by it. It is really integration within the hospital, but it's about multidisciplinary ward rounds, etc. But one of the things that was really interesting was the bed board, where the patient and the patient's family and visitors could write notes to the people doing the rounds. And the
polite ones, I hope.
I think one of them was, I want a cup of coffee. And I think the board chair said, I went and got it. But the point of it was, and they said to me, the buzzers ring less frequently because the patients know they're going to be heard and have their matters dealt with. They were discharged earlier, so shorter length of stay, and the unexpected readmissions were down because the patients and their families felt connected to those providing the healthcare.
Please thank the Minister and Mary Foley. Thank you very much indeed.
Thank you, Mary.